Thank you for joining our webinar series on medication-assisted treatment. This is the first webinar in our two-part series. So without further ado, I'd like to turn it over to Dr. Nancy Young.
Thanks very much, Han, and thank you to all of you who have joined us today. As Han mentioned, this is the first of two parts on medication-assisted treatment. And at the National Center on Substance Abuse and Child Welfare, we have been recognizing over the last really couple years increased attention to this issue in a variety of ways. And in particular, getting questions from practitioners from really around the country about different aspects of medication and what that means in terms of child welfare practice. So we're going to talk a bit today about some of the other kinds of questions that we get around child welfare practice, and particularly those of you who might be operating in a family drug court setting. And then we're very honored to have Mark Perino with us today to talk specifically about opiate treatment and advances that have been made in opiate treatment and what that means for child welfare practice in particular. And then we'll have some time at the end of the agenda to be able to go to some of the questions that you have raised by asking questions in that box on the side of your screen. As many of you know, the National Center on Substance Abuse and Child Welfare is a program of both the Substance Abuse and Mental Health Services Administration and the Administration on Children, Youth, and Families of the Children's Bureau. We are actually in our 9th year and are very happy to know that that all of you are out and working very diligently on behalf of families that cross over between these systems of the need for substance abuse treatment, child welfare practice, and the dependency courts. And as I mentioned, we'll introduce in a bit Mark Perino, who is the director of the American Association for the Treatment of Opiate Dependence, and we'll be talking in a bit about some of the specifics about treatment for opiate dependence and addiction. And in our second of our series, we will have Dr. Carol Kaltenbach, who will be talking specifically about the issues of pregnant and parenting women. So while that is certainly one of the questions that comes up frequently in child welfare practice, particularly around issues with prenatally exposed infants and infants who are detected at birth of having been prenatally exposed to substances, the treatment and management of opiate dependence during pregnancy will be the focal point of the next webinar. And let me just do a check. The date on that is, we'll make sure we have that at the end of August 4th. Sorry to not have that on the top of my head. So if you haven't already signed up for that, please do so. We think that will be very informative for you as well. It's always interesting to us to know who is hearing these webinars, and as you may be aware, they're posted on our website that you can listen to them after they've been recorded. And I was sharing with Mark a little earlier that this is an interesting group of participants that in general our webinars are often a more child welfare audience than substance abuse treatment. So it was interesting to us that just over 40% of the participants that registered were from substance abuse treatment organizations. And I guess we can speculate that response is in part some of these questions that we're hearing from treatment providers as well as from child welfare practitioners about how to handle these different kinds of medications that are used in treatment, and then, of course, more specifically, some of the issues for opiate dependence specifically. So we wanted to spend a little bit of time just talking about what are we hearing from the field. And certainly one of the things that we're hearing quite a bit about is the use of medical marijuana, and what does that mean for child welfare, and how does child welfare look at this new era of about 15 states who have passed laws that allow the use of medical marijuana. We're also hearing a lot about prescription medication misuse and abuse, and clearly that has been in the news lately and part of the initiatives from ONDCP and the federal government as they address these issues of prescription medication misuse and abuse. And then as we talk about the co-occurring mental health disorders, and particularly again in the family court settings, the complexity of understanding prescription drugs that are being used with co-occurring mental health issues, and how do dependency courts and family drug courts address these issues of knowing enough about what's going on with the individual client that has prescriptions and medications that are being prescribed for them for mental health issues at the same time that they are in substance abuse treatment for another substance dependence and addiction. And then the focal point really of this webinar was medication-assisted treatment for substance use disorders. So in part, the state of the field as we have looked at this issue, particularly over the last year, and the kinds of questions that we get in technical assistance of really some, what we would pose as some misunderstandings of the use of medication-assisted treatment, particularly methadone treatment in substance abuse, and how that relates to child safety and how child welfare responds to that. We hear frequently that there may be child welfare practitioners or child welfare policy or family court judges or attorneys that are involved with what dosing of medications should be prescribed, particularly for women who have just given birth in the perinatal period, or if this is an open case in child welfare and the woman is pregnant, some involvement of understanding what does dosing mean. And as I mentioned, we'll be talking about these issues specifically in the August 4th webinar. But we've also heard a lot of medication-assisted treatment as a reason to exclude someone from a child welfare program, and particularly family drug courts. I had the experience of being in the office a couple months ago, and someone was reporting that a family drug court had called in with some TA requests about judges that were eliminating or putting as criteria anyone who was receiving any prescription drugs could not participate in the family drug court. And I happened to be in a setting the very next day that I was in a drug court, and in fact there was a participant who came up that was had been prescribed naltrexone, and the judge said to this gentleman, well, that will mean that you won't be able to phase up, meaning advance in the phases of the drug court while he was taking naltrexone. So I know this is an issue that's out there. I was a little surprised to hear it the very next day in a very different setting of judges and attorneys in particular that have different views about the use of medications in treatment and the ways in which that influences their ability to work with families. We think it's always important to think and to go back to this sort of very broad strokes of what do we mean when we're talking about a parent with a substance use disorder and risk to children. And one of the things that we still see in practice is sort of the grouping together of all families in one category without making distinctions between a parent who may be using an illicit substance or in that abuse category, if you will, and probably if they have come to the attention of the child welfare system and they're using a substance, they probably meet criteria for a substance abuse issue. But we often find that the case plans look very much the same in those kinds of reactions as a parent who is addicted or a parent who is dependent on a substance, and that the differentiation between those different families that child welfare is working with doesn't always happen. And yet the risk for a child in the risk and safety assessment that's being conducted in child welfare often doesn't take into consideration these different kinds of ways that children are exposed to substances, both the legal and the illegal use of substances. And clearly the differentiation of when there is manufacturing that is going on, when there is trafficking that is going on, those kinds of situations and the safety factors for children are very different than when someone is dependent on a substance, and clearly different when a mother is abusing alcohol, misusing alcohol, or using illicit substances when she is pregnant. And we come back to this a lot because we recognize that those different situations pose different kinds of risk, and they require a different kind of response. That working together with child welfare and the treatment providers and the court professionals need to be able to respond to these different kinds of risks and to understand the different risks and safety factors for children when they're responding in case plans and making requirements of the court, particularly if there's been a child that has been removed or if there is a child that is being served in home, what those conditions are for the child to be able to remain at home, understanding those differences, and again, the safety and the risk factors for children are really the key that we're talking about in understanding the differences in not just the illicit substance use, but prescription drug abuse and medications that are being used for co-occurring disorders. But clearly, I think we know from the prevalence data that the largest number of children that are exposed to a parent and substance use disorders are those that are dependent on a drug, that those are the ones that typically come to the attention of child welfare, and that they are the majority of what child welfare is working with families, although the other situations certainly of trafficking and manufacturing, as I mentioned, pose certain risks that need to be dealt with in a very different way. We want to spend a little bit of time just talking about, just minimally really, about medical marijuana. And again, it's because we're hearing about this, particularly in family drug courts, and it sometimes is grouped all together as medication-assisted. And medication-assisted treatment in terms of medical marijuana comes into play when someone is participating in a case plan, when someone is participating in a family drug court, and they have a prescription to use medical marijuana. Some information that is more recent that we want to make sure that you are aware of is from this both information about which states that you can obtain information on the National Congress of State Legislators, National Conference, of State Legislators, NCSL, keeps track of these kinds of state legislation on their website, and that link at the bottom of this page will refer you to the specific state laws in your state that govern the use of medical marijuana. And more recently, in fact, just in the last 2 weeks, a letter that has come out from the Department of Justice that has went to all of the attorney generals of all of the states about the federal government's role in medical marijuana and the differentiation between medical marijuana that is being used in the treatment of chronic pain management, particularly for persons that are being supervised by pain management specialists, and those states that have recently enacted laws that would allow larger cultivation of marijuana without really the control that is needed in order to really supervise what does that mean medically. So if you have not seen this letter, we wanted to make you aware of that. We put it into the PowerPoint so that you would have the whole thing, so that you know the federal government's position on medical marijuana and prosecution for the Controlled Substance Act and proliferation of marijuana across the United States. We also wanted to make sure that you're aware of the American Society of Addiction Medicine's report that was in September 2010 that addresses the role of physicians in medical marijuana and their recommendations. This is available if you send us an email. We can send this report to you in a PDF. But they discuss the medical marijuana and the terms of use of prescriptions and medications for all kinds of diseases, and make recommendations about when the use of smoked marijuana, making a recommendation that it would be something that would be for less of 6 months, really noting the concern about the recognition of tobacco products and what that means for smoking tobacco, and the idea that smoked marijuana has little research about what that means in terms of the inhalation effects itself. So they really take a medical view of when would it be appropriate to use medical marijuana, and these bullet points are what ASAM, American Society of Addiction Medicine, proposes as when that would be appropriate. We thought that was important for you to know, because if you're struggling, particularly in a family drug court setting or in child welfare practice, about when should a prescription from a parent for medical marijuana be considered in a case plan, that you have some guidelines from, again, from ASAM about what they recommend about when that is appropriate. And if you're making state or local policy about medical marijuana in child welfare practice, that this would be something that was very helpful to you. In particular, the paper gives exactly what they, as ASAM, would expect a physician's conduct to be in prescribing medical marijuana. And again, we think that this is important because it can help you with making your own state or local policies about how to handle the use of medical marijuana if you're in those 15 states that have passed state legislation that allows prescriptions to be used as a defense if a person should be charged with the possession or cultivation of marijuana. And in general, that's what the state laws do. It allows this to be an exception to the state laws around the cultivation and use of marijuana. We didn't want to spend a lot of time on that, but again, wanted you to be aware of these resources if you have not been, because it is something, again, that we're hearing quite a bit from child welfare sites. Then the second kind of part that we want to talk about just a bit is a lot of the information that we're getting from sites around the country about prescription drug abuse. And again, this is something that's been on the cover of the weekly news magazine, that we recognize that this is something that has very much increased in the country, and that child welfare and family courts are struggling with what does this mean in terms of prescription use in the context of child welfare practice and child safety. And certainly recognizing that medications for the use of pain management as well as for mental health disorders are in fact those kinds of medications that are being reported to us that are being used that need policy set around. These are data from the treatment episode data set, as treatment agencies know that as the TEDS data, that show treatment admissions among just women. And this is the percentage of other opiates, so not methadone treatment, not heroin, as a primary substance of abuse of admission by the age group. So you can see that those that are in that age group of 25 to 34, with nearly a quarter of treatment admissions for these particular substances, other opiates, are in that age group, and certainly that age group of parenting women and childbearing ages of the 18 to 24-year-olds. So we recognize that this is a somewhat newer phenomenon for child welfare to be working with. And then if you look at the treatment admissions for other opiates, not heroin, not methadone, as primary substance of abuse, the states with the highest percentage of women admissions. And if you happen to be in one of those states, then you're certainly dealing with what does this mean in the context of child welfare practice. We also recognize, and while this isn't clearly a complete list of the kinds of medications that are narcotics and analgesics that are used for pain management, these are usually short-term. They have a high addiction potential. They're short-term pain relievers that you may be getting individuals in practice that are using these kinds of medications. And I think although it's much probably more widely used than the issues that ASAM was addressing in medical marijuana, but those standards that they lay out for physicians seem to be applicable in this also, and not unreasonable for child welfare practice to look at those standards about making sure that this is a physician that has a relationship with the patient, that there is a diagnosed condition that is being treated by using these kinds of medications. But again, important to recognize that it's the context of risk and safety for the child, and individualizing what does the use of this particular substance mean for that particular family in the context of medical conditions versus the context of substance abuse that is posing risk to children, particularly as you look at neglect kinds of situations. Finally, the other aspect that we wanted to recognize, because we, again, have this kind of coming into us as all jumbled up in terms of the different kinds of medications and the different kinds of substance abuse that's going on, is the recognition that the co-occurring mental health disorders in practice, that about more than half typically in substance abuse treatment have some type of co-occurring mental disorder. Usually they're anxiety, depression kinds of related. Also, they may be the more serious kinds of mental disorders, but that the other side of that those individuals coming into mental health settings, that somewhat less than half of them have a co-occurring substance use disorder. This is information from the treatment improvement protocol put out by the Center for Substance Abuse Treatment on substance abuse treatment for persons with co-occurring disorders. If you don't have that in your office, it's readily available to you and would be very helpful as you're looking at child welfare policy about medications and the use of medications. Certainly recognizing that the complicating presence of co-occurring disorders, meaning that there may be longer time that the person is in treatment, that they may have rehospitalizations for depression, they may pose suicide risk when there's co-occurring disorders. Those are all complicating factors for substance abuse treatment agencies, again, that child welfare needs to be aware of. Again, we don't intend to go through an exhaustive list of these medications, but recognizing, again, the different types of medications that are being used for co-occurring disorders, again, we think is important, particularly if those of you that are participating today may be in charge of training programs for child welfare. And these are, this is information that's available to you through some of the training resources of the National Center, but recognizing that child welfare workers need the information about the different kinds of medications that are being used in the treatment of co-occurring disorders, as well as the treatment of substance use disorders. Again, we put this into the PowerPoint so you have these lists that you can come back to and refer you to the tip 42 for more information about each of these different kinds of categories, and wanted you to have some of the drug names that you would often hear as the kinds of prescriptions that are being used with persons with co-occurring disorders. Then we want to turn our attention to medication-assisted treatment for substance use disorders that we're talking about more specifically used in a treatment setting during detox or perhaps through ongoing maintenance of recovery for individuals with substance dependence and addiction. Recognizing that the detox phase of treatment it says specifically the National Institute on Drug Abuse is not showing that that is different than patterns of use after detox unless there is a referral to ongoing treatment. We hear frequently in child welfare practice that they may even have paid for detox for an individual without ongoing support for ongoing treatment, and that it's recognized that that detox process and medications that may be used during detox is only that first step in the treatment process, and in and of itself is not sufficient to provide that long-term stability that a parent may need in order to satisfy the requirements of safety for their child over the long term. Recognizing that there are substances that are used and medications that are used for the treatment of substance use disorders, particularly for the legal substances in alcohol and tobacco, and there are other drugs that are also being used in alcohol dependence that Mark may speak to specifically as he gets into his presentation. That there are other substances besides Antabuse now that are being used for the withdrawal period of alcohol and showing promise in using that in terms of ongoing recovery from alcohol dependence. And then getting into then the main focus of the remainder of this webinar with looking at opiate dependence and the kinds of information that Mark will be talking about more specifically, with the difference between the opiate and opioids, the synthetics that are painkillers, including oxycodone and hydrocodone, which is commonly known as Vicodin, and the medications that are available to treat dependence that you may be hearing about from treatment providers that child welfare practitioners are working with, and some of the advances that are being made in medication development. That's exciting news in the treatment of substance use disorders, but our sense is not particularly well understood yet in policy and practice in child welfare. So we have a polling question just to get started before I turn things over to Mark. And Han, I'm going to turn this back over to you to conduct the poll.
Great. So we wanted to ask you to respond to this statement. There is no way a parent who is receiving medication-assisted treatment for substance dependence can be an effective parent. All right. It looks like the majority of you either strongly disagree or disagree.
So let's turn things over to Mark with the results of that and have him perhaps take that into context as he begins his presentation.
A very good prelude, and it certainly indicates to me that there seems to be disagreement that when you're using medications to treat opiate addiction with either methadone or buprenorphine or perhaps these newer medications like Vivitrol that are being used, that by virtue of the individual taking such medications to treat the opiate addiction, that prevents them from being an effective parent. I take it, Han, that I am correct in making that assessment.
Yes, you are correct.
Okay. So let me tell you a bit about what you will see in the following slides. First, we'll be giving you a sense of where we are in the United States at the present time in treating chronic opiate addiction, the history of the science, the evidence in supporting what that treatment does, the medications that are primarily used to treat opiate addiction right now, which is methadone and buprenorphine, and then where we are in terms of the use of methadone for pain management, which has increased in the past 10 years, and the difficulties, challenges that's created. And then a research study that we've done, and as was already discussed in the prelude to this discussion, that prescription opioid use, abuse, and addiction are now becoming a very critical national problem. And then some closing points which are responding to some of the frequently asked questions, which I think are reflected in that first poll. Just briefly, before I tell you what this map means, the association represents 850 programs, opioid treatment programs in the United States and in Mexico. We work with our international associates, Europad, which represents 23 nations and another 500 treatment programs. The map that you see is from the Center for Substance Abuse Treatment. These dots represent independent opioid treatment programs, otherwise known as OTPs, and that's how I'll reference them during the course of the webinar. And there are about 1,230 of these treatment programs. All of them are certified by the Center for Substance Abuse Treatment in SAMHSA. They collectively treat about 285,000 patients on any given day. The clear majority of these patients, of these 285,000, receive access to methadone maintenance in these treatment programs. About 5,000 are using buprenorphine, and I'll explain that in a moment, what that means. You will notice there are 3 states in particular that do not provide any access to care, and that's North Dakota, South Dakota, and Wyoming. In addition to the federal government regulating these programs through CSAT, and that's an accreditation-based system of care, most of the programs are either accredited by JCAHO, the Joint Commission, or CARF. And again, that's under CSAT jurisdiction. But in addition to the federal oversight, you have additional oversight from the state authorities, which are called the State Opioid Treatment Authorities. As a prelude to the next slide, it's fair to state that these medications represent the most studied and evaluated medications for the treatment of any disease that we've got. That is not a grandiose point, that's a point in fact. So why don't we go to the next slide, which will show the increase in the use of buprenorphine, which is one of the more newly developed medications. And this slide shows you the increase in the use of buprenorphine through pharmacy distribution. Specifically, this means this is the medication that is prescribed out of a physician's office, and this is a physician's office that is certified and approved by CSAT under federal legislation called the Drug Abuse Treatment Act of 2000. As you'll note in reviewing the slide, that it shows that you have medication that was started early on, and then it was used through, and it's used at the present time, in 2003. What you will also see is that there are approximately, and I'll give you the numbers to this, there are approximately 300,000 patients who gain access to this medication in physician practice settings. And we don't know much more about that because it's not a centrally collected number. that is reported through the Center for Substance Abuse Treatment. We imagine through their reports that there are over 7,500 physicians who are actively using this medication to treat chronic opiate dependence through the private practice. When you go to the next slide, you will see the comparison of how buprenorphine is used in an opioid treatment program or an OTP. You'll see in that slide that it's a much smaller number. This slide shows millions of units of buprenorphine used. The next slide shows that there are about 450,000 units prescribed in OTPs. That converts to about 5,000 patients. Once again, it shows you that there's been a limited distribution in the OTPs. This is primarily because the medication was intended originally to be used by physicians in private practice in treating their patients. We anticipate that CSAT will issue a Federal Register notice very shortly, which is likely to allow the increased use of this medication in the OTP. For the point of this webinar, both medications are extremely effective in treating opioid addiction. The differences in understanding their use is understanding pharmacology. The general rule of thumb is that if a patient has a longer-term narcotic addiction prior to entering treatment, if they have a more significant opioid dependence, that they are likely to use or benefit from a medication like methadone, which is a pure agonist, whereas buprenorphine is a partial agonist and antagonist. Generally speaking, buprenorphine will be used in a population that is not having as much long-term pre-treatment duration of opioid use, or generally can stabilize on a slightly lesser dose. And I know there may be some questions about that, but that sets as a prelude. Once again, they're both extremely effective medications. There is oversight for the OTP system at the federal and state level, which I discussed. There are no standards per se in how physicians will use buprenorphine in their practice setting. The requirement for physicians under the Center for Substance Abuse Treatment, which follows the federal legislation, is that the patient has to have access to the medication and that the physician will generally experience an 8-hour training course which are offered by professional medical societies. Vivitrol is a new medication which has just been approved by the FDA to treat chronic opiate addiction. It has been used to treat alcoholism. The difference is it's an injectable medication. It's used once a month as opposed to methadone, which is used each day, generally with most of the patients going to the treatment program either 4 or 5 times a week. Buprenorphine is generally given to a patient by prescription, and patients typically get a month's supply once they're stabilized. So now let's go to the next slide.
Mark, could I interrupt for just a second and ask you to go back to the explanation of agonist and antagonist? Could you just do a little bit of explanation about that?
Yes. I mean, an agonist, a full agonist like methadone, they're binding to neuroreceptor sites in the brain. And a subsequent slide is going to describe the neurochemistry of this and explaining how the medications will bind. Methadone binds in such a way that it is an agonist. It's sort of imagining a sort of lock and key fit into the brain, where if somebody tries to use another opiate, let's say heroin as an example, that the access of methadone into the neuroreceptor site will prevent an individual from feeling the euphoric effect of the medication, in this case, or heroin, the other drug. Whereas an antagonist, if the individual uses a drug, so if a person uses heroin and they're maintained on methadone, if they're on the right dosage of methadone, what's called the blockade dosage, they are not going to experience any euphoria from using heroin. However, they won't be made to feel sick. They just won't feel the euphoric effect. With an antagonist like naltrexone, or even a partial antagonist like buprenorphine, if the patient uses heroin or other drugs, opioids, they will feel withdrawal symptoms. That's the antagonist nature of the drug. It also binds to the same neuroreceptor sites in the brain, but it produces a very specific reaction. Patients will go into withdrawal if they use an opiate on top of an antagonist. So hopefully that clarifies the question.
And one more follow-up to that. Something I hear a lot from practitioners is that people use methadone to get high, and that they get high using methadone. Can you explain that?
Well, methadone, because it is a pure agonist, can create a euphoric effect, especially if the patient is not stable in treatment, or if the patient isn't using the medication at a stable dose each day and under supervision. Does methadone cause euphoria, or will it create a high in a patient who's stable in treatment, who is not using other drugs? And the answer is no. It does not create a euphoric effect. It does not create a buzz. Sometimes people will report, well, the patient says they feel good while they're on methadone. And that, let's presume for the moment that these people are not using or abusing other drugs. They're not drinking. They're not using marijuana. They're not using benzodiazepines like Valium or Xanax, and that they are simply maintained on a steady dose state of methadone. This will not create euphoria. It will not create a state of being high. This is not a speculation. This is not an opinion. This is based on science, all the research that NIDA has supported over the years, and clinical practice. So can patients, if they want to get high on methadone? The answer is yes, but it generally means they are unstable, or they are not in a treatment program, or they are using or abusing other medications. Does that provide some clarity?
Yes, thank you very much.
Okay. And I see that there's another polling question up.
This is Han. I'll go ahead and read the polling question. Let me go ahead and launch it. All right. Please respond to the statement. People who abuse alcohol or drugs have a disease for which they need treatment. All right. It looks like almost half of you strongly agree with the statement, and about a third of you agree with the statement.
Okay, so now this may run slightly counter to the first polling reaction. So let me go to that addiction as a brain disease and giving you an underpinning to what I perceive as your response. Alan Leshner is the former director of the National Institute on Drug Abuse, and he wrote an article in the publication Science and Technology during 2001, and it really talked about addiction as a brain disease. And the next slide is a quote from Dr. Leshner's article. And while you can read it, the core concept has been evolving with scientific advances over the past decade, and that drug addiction is a brain disease that develops over time as a result of the initial voluntary behavior of using drugs. The consequence is virtually uncontrollable compulsive drug craving, seeking, and use that interferes with, if not destroys, an individual's functioning in the family and in society. This medical condition demands formal treatment. What Dr. Leshner is getting at is not what we talk about in terms of a person who occasionally uses drugs or individuals who have the ability to use drugs, walk away from them, not become either dependent on them or addicted to them later. These are individuals that are chronically abusing drugs. It is uncontrollable. It's gone past the issue of willpower. These are individuals who are not able to function either at work or in society, lose family relationships or disrupt family relationships, and then do need access to formal treatment. Interestingly, approximately 15% of people who need access to formal treatment are getting it. And that is related to either resources, it is related to access to treatment programs in a respective community. It's perception on the part of the individual that says, I don't have a problem, even though they may have lost a job or they may have lost a relationship. They still perceive they don't have a problem. But Dr. Leshner is getting at the fact, and some subsequent slides will support this, that this is a chronic and relapsing disorder. It is a disease. It's not perceived as a moral failing. It's an illness that is treatable, and we do have effective treatments. I'll say something else which is slightly tangential to the discussion. While I'm focusing on the issue of medication-assisted treatment for opioid addiction, which includes the medications that have been discussed, methadone, buprenorphine, naltrexone, and now the newly developed approved Vivitrol, it's also understood that medication-assisted treatment involves other services, counseling and ancillary services, which we'll talk about. However, this is not to suggest that every person who becomes opiate addicted will need a medication. There are some patients who will go into inpatient therapeutic communities and do well also. So while our focus is the use of medications, I'm not saying that it is the exclusive treatment intervention that's available for a patient. So if we go to the next slide, we get into the principles of drug addiction treatment. And this is a research-based guide which is developed by the National Institute on Drug Abuse, and it was revised in 2009. It was originally published in 1999. I recommend this for your reading, and I believe that this is made available to you, and you can see the reference for electronic access on the bottom of this slide. This is an extremely effective presentation of the best research that's been done in this particular area. And the next slide focuses on one of the references from this, which is addiction affects multiple brain circuits, including those involved in reward and motivation, learning and memory, and inhibitory control of behavior. Some individuals are more vulnerable than others to becoming addicted, depending on genetic makeup, age of exposure to drugs, other environmental influence, and the interplay of these factors. So what this says to you is what you have already determined, I would imagine, is that addiction is a disease. There are multiple pathways, and you can say how come some individuals with similar exposure to the use of a drug become addicted and some others don't become addicted. And that's directed based on what's in this slide from the NIDA research booklet, which is that some brains are different. They are more susceptible, making the patient more vulnerable than others. And this is based on genetic makeup and the other factors that are listed. The next slide is going to reference a critically important resource to the programs in the country. And once again, you see the electronic access at the bottom of the slide. The title of this is the SAMHSA CSAT Tip 43. It's Medication-Assisted Treatment for Opioid Addiction and Opioid Treatment Programs. This is recommended reading. There's also a chapter specifically on medication-assisted treatment for opioid addiction during pregnancy, and that's chapter 13 in this reference book. This reference is used by all of the OTPs in the country, and it is comparable to the regulations through accreditation oversight that CSAT has over the programs. So this is a very unique thing where you have this treatment improvement protocol which provides the most comprehensive available reference for the use of these medications in treating chronic opiate addiction, but it is matched by regulatory oversight. One of the guiding principles in this Tip 43 in the next slide, and you see that this is the reference. It's published in 2005, and the next slide goes into the issue of discussions about whether addiction is a medical disorder or a moral problem have a long history. Decades of studies have supported the view that opiate addiction is a medical disorder that can be treated effectively with medications administered under conditions consistent with their pharmacological efficacy. And this goes to when treatment includes comprehensive services, psychosocial counseling, treatment for co-occurring disorders, medical vocational rehab services, and case management services. The reason I reference this particular quote from Tip 43 is to underscore the fact and a principle that the use of medication alone to treat a chronic opioid addiction is not what is recommended for the principal patients that come into our treatment programs. Other services are going to be essential. That's why they call it medication-assisted treatment. The medication is a component of treatment. Medication is not, in and of itself, the treatment intervention. And this is an evolving issue, especially as patients discuss their recovery from their prior addiction. And people can be in recovery and still use medication to treat their chronic addiction. Recovery does not mean that the individual must discontinue either the use of methadone or buprenorphine or Vivitrol if it comes to it. And this is an issue that may come up later or might be reflecting some of the attitudes that were reflected in the first polling results. If you go to the next slide.
Mark, before we do that, we actually had a question that came in specific to the use of Vivitrol for alcohol dependence and the implications for child welfare, particularly when it's getting exactly at the point that you're making, that Vivitrol being used in place of, if you will, traditional treatment, that child welfare is sort of grappling with an individual parent comes in and says, I'm on Vivitrol, not participating in a comprehensive treatment program. What would you recommend to that child welfare practitioner who's trying to work with that particular situation? I mean, clearly your statement that this is not sufficient, that it's medication assisted, what should this individual do in terms of trying to work with that individual?
Well, the first thing I do is get that individual to sign a consent. So if I'm the child welfare worker, I want to talk to the physician who is treating that patient. And I want to ask that person, what else is being done aside from giving this individual Vivitrol? What has been recommended in terms of access to counseling, other therapeutic services, whether it's family, counseling, what is happening to that human being? What's happening in the life of that human being, aside from the fact that they're getting access to a medication to treat their addiction? So the first issue is that it is important, and it is therapeutic, that they are getting access to a medication. And it's a sort of obvious point, but it is also insufficient if that individual, and let's face it, when I'm providing some general guidelines and recommendations, it's sufficient to say that no two people are alike here. There are general principles that guide their treatment. Is it possible that someone along the line, after taking these medications for an extended period of time, Vivitrol, methadone, buprenorphine, will not need access to other services because they've been stabilized, they've had access to counseling, they've worked through a number of the problems associated with their addiction or their disease? The answer is yes. But it's when that happens. At what point? So if a person comes in to a child welfare worker and says, by the way, I'm on Vivitrol, I've been using this medication for a couple of months, and that's what I'm doing right now, and there isn't any other access to treatment, and I claim to be perfectly fine. I've worked through many of the issues that got me to abusing and addicted to alcohol in the first place, that's where the child welfare worker really does need to be in contact with the practitioner to determine exactly what is being offered to the patient. Does that help?
Great. Thank you very much.
So now we get into the second statement from Tip 43, and this is the last point I'll make about the science of and the neurology of addiction. Dr. Vincent Dole, along with his wife, Dr. Marie Neiswander, worked with folks at the Rockefeller University, including Dr. Mary Jean Creek, and really developed the use of methadone maintenance as a treatment for opiate addiction. It was the first medication that's used in this country and in other countries, and this is an important quote, which comes from also Dr. Dole's original research. And he described the medical basis for methadone maintenance as a treatment. It's corrective. It's normalizing neurologic and endocrinologic processes in patients whose endogenous ligand receptor function has been deranged by long-term use of powerful narcotic drugs. Why some people who are exposed to narcotics are more susceptible than others to this derangement, and whether the long-term addicts can recover normal functions without maintenance are questions for the future. At present, the most that can be said is that there seems to be a specific neurological basis for the compulsive use of heroin by addicts, and the methadone taken in optimal dose can correct the disorder. I bring this slide up as a method of indicating that there is a bedrock of science and evidence to support the use of medications to treat chronic opiate dependence and addiction. And it's important as you read through the references that have been made, and obviously this is too limited an opportunity to guide you through all of the evidence. That's why you have the two specific references in both the NIDA research guide and Tip 43. And I advise you to read through them. They're both accessible electronically. The issue here, and you'll see this in a subsequent slide about duration of treatment, is that what you don't want to do as child welfare workers or even as treatment providers or state officials is to provide some arbitrary limit on the individual's duration of treatment. There is no arbitrary limit. There's no one where you can say, you've been in treatment for 1 year, that should be sufficient. Now you should end your treatment, and that will make you a better human being, or that will make you more recovered, or that will make you a better parent. And this is the crux of part of this presentation, which is the use of medications when properly supervised, and I mean properly supervised in the hands of a practitioner, whether it's an OTP, which is regulated, or a DATA 2000 practitioner using buprenorphine. The issue here becomes, is the patient progressing in treatment? What you don't want to do is say to the individual, we think your treatment has run its course, it's long enough. In this particular case, the rough equivalent would be, let's say, a psychiatrist saying to a chronic depressed person who's tried for years various interventions but seems to only be stabilized while they take an antidepressant, you've achieved stability, now let's see what happens to you once you leave or you stop taking the antidepressant. Or a cardiologist saying to a hypertensive, you've been stable now, your blood pressure is now within normal limits, that blood pressure has been driven by better exercise, let's say, healthier eating, but also taking this medication. We think it's now time for you to stop the medication. You almost never hear a cardiologist say that, because most practitioners, once they have a patient's disease under control, tend not to disrupt the use of a medication that helps achieve that stability. Which takes us to the next slide. And this comes from the National Institute on Drug Abuse. And this slide talks about matching patients to individual needs. And that you've heard me reference this already, and that no single treatment is appropriate for all individuals. and effective treatment attends to the multiple needs of the individual, not just his or her drug use, and that the treatment must address these broader issues. It reinforces the point that I was asked about Vivitrol. This is based on absolutely hundreds of millions of dollars of research over the course of 40 years. We have not concluded these matters lightly or without external scientific evidence. We get to the next slide about duration of treatment. This is also from the National Institute on Drug Abuse. And again, the duration depends on the patients, the problems, the needs, that less than 90 days is of limited or no effectiveness, and a minimum of 12 months is required for methadone maintenance, and longer treatment is often indicated. Now, there's a polling question that come up, so I will turn this back over to you, Han.
All right. Please respond to the statement. After 6 months, a parent receiving medication-assisted treatment for substance dependence should be completely drug-free, including from medication-assisted treatment medications.
While we're doing that, Mark, let me just mention that, in fact, one of the questions that came in is that, you know, it's very difficult sometimes for child welfare practitioners to look at medication-assisted treatment and the perhaps longevity of that in the context of the time requirements that they have in terms of making decisions about reunification or termination of parental rights, that they have time pressures for you know, making those decisions and a permanent plan for a child in a year. What sort of things should they be looking for in terms of stability for a parent who may be on long-term methadone or other medications that perhaps they are appropriate to be on long-term medication, but what kinds of things should they be looking at in terms of stability that goes along with the use of those medications for making decisions about permanency for their children?
Well, certainly some of the markers or the indicators of stability is, does the patient appear to be stable? In other words, not in crisis. That the patient is able, from one day to the next, to demonstrate that they are taking care of themselves, first and foremost, that they are compliant with the program's policies, which means that the patient should sign a release or consent of information so that someone from child welfare can speak directly with the people responsible for that patient's care, whether it's in an OTP, an opioid treatment program, or a DATA 2000 physician's practice. And from my point of view, that's an important communication. And the issue of stability or markers based on what the patient presents is, if the patient is compliant, is the patient participating in counseling in the program? Is the patient stable, not using or abusing other drugs? And this, by the way, includes marijuana. It includes other drugs of use and abuse. And it goes to the issue of somebody saying, well, I have a psychiatric comorbidity. I need an antidepressant. Fine. Who's prescribing that antidepressant? And is that treatment coordinated through the OTP? The other issues of stability is that obviously is the patient, we assume that, and this is from CSAT as well as NIDA, that a patient is not involved in the criminal justice system, that this individual, if they are taking medications, are using them as prescribed and they are stable in their care, and that they have a stable living home environment. Obviously, if before you get into reunification with a child, the patient has to be in a stable living situation. These are basic markers. And the truth is it will not be materially significant if the patient continues to be enrolled in a medication-assisted treatment program. That does not imply any lack of stability. In fact, what the research has shown is that it supports stability of the patient. And that's the case given the high relapse rate for individuals who leave treatment either if they're discharged or they voluntarily discharge themselves. The rate of relapse is very high at about 75%. Han, do you want to go through the polling result?
Yeah, this is Nancy. Yeah, I think what's really important in this slide, as well as the other polling questions that we've done, although the vast majority have been in one direction, either disagreeing or strongly disagreeing in this example, there are some who don't, who hold an opposing view. And I think that this is what we hear frequently in practice, is that there may be some individuals who don't see it the same way as perhaps the majority. And if an individual family has a caseworker or a judge who feels the opposite or believes the opposite, in this example of a person receiving medication-assisted treatment after 6 months, that they should be completely drug-free. There's a small percentage, but if you do the neither agree or disagree, about 1 out of 5 are saying that they disagree with that statement, that they should be completely drug-free. So, we recognize that there's not only a value base to these decisions, there's a scientific basis of education that needs to happen. And if you're in a jurisdiction that you're running into these kinds of situations, that there are some individuals who perhaps are in policy-making positions, that we would invite you to contact the National Center if we can be helpful to you in that, ensuring that the basic information and the education that needs to happen around these issues is available to these people who may hold a view that's a value-based or a belief that may not be consistent with the science about treatment for addictive disorders.
Well, I think that this is a fairly important point here, because if you ask the question and say, would it be best for a parent who is addicted to opiates or who has been previously addicted to opiates to be completely abstinent from the use of all medications, all, including methadone, buprenorphine, isn't that the best state in some theoretical world? And the answer could be yes. On a practical side, however, the question becomes, does it necessarily make the parent more responsible, better able to attend to the needs of the child, if they are not using a medication such as methadone, buprenorphine, or Vivitrol? And the answer to that is no. Forcing the individual patient to discontinue their drug use based on a theoretical perspective, disconnected from how the patient is doing, is incorrect. And it's not this is not a supposition. This is based on what we know to be the evidence that says if patients who are chronically opiate addicted are compelled to leave treatment, either to be reunited with children and family, that ultimately you risk forcing that person into an eventual relapse. That relapse may not be seen immediately. It may come in a month or 3 months. But forcing the individual to discontinue their treatment ultimately sets that patient and that family up, because you're taking a risk, given what we know about a 75% plus relapse, that patient is going to be forced into some future relapse based on the elimination of the medication. You can discuss this in broad philosophic terms. Why should that be? Which is why you saw the prior slides on the neurology, on the what Dr. Alan Leshner said, that addiction is a brain disease, the NIDA research in support of it. That's what that scientific underpinning is all about. Does that provide some clarity?
It absolutely does. Thank you very much for that. And I think, Han, we can move on to the next slide.
Sure. The next slide it basically makes this point, which is leaving methadone treatment, lessons learned, lessons forgotten, lessons ignored. This is from the Mount Sinai School of Medicine, and we finished with the duration of treatment slide. This is the slide that follows it, and this really is the one that makes the point about this, which is by Dr. Stephen Magura and his associates. It's the Mount Sinai Journal of Medicine in January of 2001, and I'll say to you, if you have an interest in accessing this, Han and Nancy, I'm happy to get this to you as well. But what this study did is looked at 30 separate research studies which looked at what happened to patients when they were discharged from medication-assisted treatment. In this case, the opioid treatment programs, which principally use methadone. So Dr. Magura and his associates looked at over 30 studies in this field and concluded definitively, and I'm quoting from it, that the detrimental consequences of leaving methadone treatment are dramatically indicated by greatly increased death rates following discharge. And ultimately, this recommendation that says the patient should withdraw is not based on what we know to be long-term clinical evidence. That's generally used to suit the values of individuals who are not as aware of the consequences of what they're recommending. And we go to the next slide, which is one of the foundations, and it goes to the issue of stability. And I'll put this in. It's the slide about crime among the patients. This is the purple slide with the sort of reddish and yellow bars to it. This is not the quote by Vincent Dole. That's it. That Dr. John Ball completed this study. While this is dated to 1991, this is as applicable now and as it was then. Basically, I guess, whether the purple bars represent pre-admission crime among the patients, and then the yellow bars represent crime after the patient has been admitted to treatment. The hallmark of this treatment, almost from the beginning, has been the reduction of drug-related crime as the patient enters and remains in treatment. This has been replicated in many studies in the United States and throughout the world. Dr. Ball's study focused on treatment programs in Baltimore, Philadelphia, and New York. It is a foundation issue. So what happens when the patient is forced to end treatment? The reverse applies. You have now then the issue of forcing the patient back out into using various drugs. Now, by the way, while this was a time when most of the admissions to OTPs were based on heroin use, clearly we've seen a shift, which I'll talk about in a subsequent slide, on a study that's been done, which shows that prescription opioid use, whether it's the oxycodone, hydrocodone products, have now dominated admissions to treatment programs throughout the country, but most especially in the Southeast and along the Appalachian Trail. So now we can go to the next slide, which really makes the point and sets up what we deal with in terms of psychiatric comorbidity. And Dr. Dole, once again, one of the founders of methadone maintenance as a treatment intervention for opiate addiction, says the problem was one of rehabilitating people with a complicated mixture of social problems on top of specific medical problems, and that practitioners should tailor their programs to the kind of problem they were dealing with. And he talks about the strength of the early programs as designed by his wife, Dr. Neiswander, was the sensitivity to individual problem. The stupidity of thinking that just giving methadone will solve a complicated problem seems to me beyond comprehension. That reinforces our discussion about Vivitrol and about the use of medications and what, in fact, child welfare workers should be looking at as people are in treatment for chronic opiate addiction. And the reason that we're dealing with a complex problem is also seen in the next slide, which deals with the lifetime and recent prevalence of psychiatric comorbidity among methadone maintenance patients. Now, Dr. Ball, again, the study of 1991 is focusing in his sample among male methadone patients. All you need to do is look at the top two items, serious depression and serious anxiety. You've flipped ahead to the USA Today article. So I would go back to the psychiatric comorbidity, this slide. Now, I will frankly concede that part of the problem here is that, in my judgment, there is not sufficient recognition of diagnosing and treating the psychiatric comorbidity in this patient population. We know the serious depression and anxiety. When people ask, or child care welfare workers ask, why is it that will people who are stabilized on methadone continue to use or abuse other drugs? Generally, it's because the psychiatric comorbidity has not been sufficiently diagnosed or treated. And part of this is that you don't have psychiatrists at the program site in many OTPs, or there's limited referral capability or communication between the OTPs and available psychiatrists in the community where they're close enough to the physical space of the OTP. It's a significant issue, and this is why we're dealing with a complex disorder aside from the issue of hepatitis C or HIV infection. So it's a significant issue and one that bears discussing. Next, we go to a series of slides, and this is now we're coming to really the end stage of the presentation. The next slide is showing this USA Today article about deadly abuse of methadone, tops other prescription drugs. Clearly, this is a significant issue because methadone has been used now more widely for treating pain than it is in treating chronic opiate addiction. As you may recall from the prior slide, the map I showed from CSAT, there were 285,000 patients in roughly 1,230 OTPs in the country. When you go to the next slide, which is from the Food and Drug Administration, you will notice since 2002 the increase in the use of methadone for the treatment of pain. This is a very significant issue. This is the slide with the purple bars, and it's the slide after this USA Today article. This FDA slide shows that methadone has been used to treat chronic pain increasingly from 2002, and this goes to 2009. And are you able to load up this particular slide? There it is. And you will notice that this is in unique patients in thousands. This means that more than twice the number of people who are being treated in opioid treatment programs with methadone are receiving it for pain. And the majority of the physicians prescribing such medication are family practitioners. We've also seen, as a result of this prescribing, an increase in methadone mortality. Over 5,000 patients per year are assessed to have died from methadone-related mortality. There have been 4 published national reports on this topic that's seen in the next slide by the U.S. Department of Justice and the National Drug Intelligence Center of November of 2007, and the following slide shows the quote from 1999 to 2006. The number of methadone-related deaths increased significantly. Most deaths are attributed to the abuse of methadone diverted from hospitals, pharmacies, practitioner, and pain management. Some deaths result from misuse of legitimately prescribed methadone or methadone obtained from the OTPs, including use in combination with other drugs and alcohol. I'll make a point of this. When you have methadone-associated deaths in the OTP setting, usually it's in the first 2 to 3 weeks of treatment as the patient is being stabilized and is likely abusing other drugs, most specifically benzodiazepine and alcohol. This is a particularly lethal combination for patients who are in treatment programs because methadone is a central nervous system depressant, as are benzodiazepines and certainly alcohol. That's where you have mortality generally through the OTP. When you look at the next slide, which talks about methadone and associated overdose deaths, this is the United States General Accountability Office. This is the last published national report of March of 2009, and it makes the point in the slide in the quote that follows, which is the subsequent slide, that most officials from federal and state agencies, as well as experts in addiction treatment and pain management, cited the increased availability of methadone due to the use of pain as a key factor in the rise of deaths, while some added that addiction treatment was not related to these increased deaths. And that is the case, and CSET's about to release its own report very shortly based on a large meeting they convened approximately 1 year ago. We get now into the last phase of this discussion, which is the result of a study that ATOD has managed through the auspices of the Denver Health and Hospital Authority. It's called the RADARS system. It's a risk surveillance system, and ATOD has one of the 5 signal sites in this system, which involves approximately 75 active OTPs in the United States. The National Development and Research Institute's NDRI is the entity that analyzes all of the data that will follow. We started this in January of 2005, and we did this because we were becoming more aware that prescription opioid addiction became a leading cause of patient admissions to OTPs. I already referenced this in some of the southeastern states, but it's a significant issue, and these data support this. The next slide basically shows the primary study aims, which is to determine the lifetime and current prescription opioid prevalence among OTP enrollees, to identify factors associated with primary prescription opioid abuse, and the source of the prescription opioids. And the next slide shows the prescription opioids that are under study. This is similar to the previous slide that was shown during Nancy's presentation at the beginning of the webinar. So there's a consistency in the medications that we ask patients to check as they're being admitted to treatment. And the next slide shows this is a large study involving over 46,000 patients, and this is just capturing the data from January of 2005 to January of 2011. And the subsequent slide really talks about the characteristics of the patients, these new OTP enrollees. You're going to see 2 bars here. One has when patients indicate they're abusing prescription opioids at admission to treatment versus they are using heroin. So there are some significant issues to focus on this particular finding. You will note that for the patients who are primarily using prescription opioids as they're admitted, it's the first time they're in treatment in an OTP versus their counterparts who are using heroin who have previously been treated in an OTP. When you go down a bit, you will also note a difference that when the patient has ever injected the primary drug, and this was a surprise to us at the beginning of the study, that 33% of the patients who indicate that they're abusing prescription opioids inject them. We're obviously not surprised to see that 77% of people who are using heroin are injecting the drug. What you'll also see is a change in the next slide of age distribution. This is also significant. About 10 years ago, many people in the treatment sector knew that the patient population was aging, was getting older. Well, now with prescription opioid abuse and addiction, it's reversed itself. Of the 46,000 patients who were in this study since January of 2005, you will note the significant number of patients in the 18 to 25 age group or 26 to 29. You will also notice in the source of primary opioids and prescription opioids, you'll notice this in the next slide, and patients, of these 46,000 patients, they can opt to endorse different responses. So dealers, friends, they have multiple options. But you will note, and this is consistent with other federal findings in this topic, that when patients say who do they get their prescription opioids from, the answer is 85% get it from a dealer and 53% get it from a friend or relative. Doctor's prescription directly to the patient is 29%. ER is 13%. A myth is that prescription opioids are purchased through the Internet. That is not the case, and our findings are consistent with federal agency findings as well. So what I'd like to do is go to my closing points and then respond to questions that have come up or the poll findings that have come up as well. And these closing points are an attempt to respond to what I perceive as some of the most frequently asked questions in this area. One is that methadone in a stabilized patient will not cause sedation or prevent the individual from being a responsible parent. I recognize this runs counter to one of the earlier poll findings. This is what we know to be the scientific evidence in support of this treatment. We also know that methadone maintenance treatment and buprenorphine do not have the narcotizing effects of heroin and does not trade one addiction for another. Many times the critics of maintenance pharmacology for opiate dependence addiction take the position, and they use this in a disparaging sort of way, that giving these medications to treat chronic opiate addiction is like giving bourbon for someone who is addicted or alcoholic with scotch. The reason that is not true is because these medications do not create the euphoric effect of heroin or a number of the prescription opioids which are crushed or snorted or injected. And this is an important sort of difference to understand, that the medications specifically bind to the neurological sites, and I talked about the endorphin system in a prior slide. This issue of, well, it's trading one addiction for another does not bear the evidence that we know in science. This is more of a pejorative opinion. This is a sort of feeling opinion rather than one that's based in reality. Methadone is not harmful to the fetus if the mother is stable and under the medical care of an OTP. Another critical point, this is already incorporated in the treatment improvement protocol that I referenced. Again, I suggest you read Chapter 13. You have that electronically available to you. I know that in the subsequent webinar, you'll have Dr. Carol Kaltenbach discuss these issues in much greater detail. She's certainly one of the nation's foremost authorities on this topic, is extremely respected, is not only an expert treatment practitioner, but a fantastic researcher. She will go into this in greater detail. This issue, however, that says, well, the mom is in treatment, either methadone or buprenorphine, let us make sure that that mom gets off treatment before the baby delivered. This is the worst thing you could possibly recommend. This will put the fetus into great distress and runs counter to proper established therapeutic care for the mom and certainly for the baby. And remember, you're treating the mom who is the patient. And if the mom is stable, the fetus will be stable too. This idea of saying to a patient, you're in your third trimester, isn't it better to be not using methadone or prematurely withdraw the patient, this almost always creates a condition that puts the fetus into acute distress and could create spontaneous abortion. The next slide of these closing points, and this is also based on the TIP and the scientific studies, that methadone has been accepted since the late 1970s to treat opiate addiction during pregnancy. And in 1998, the National Institutes of Health consensus recommended methadone maintenance as the standard of care for pregnant women in opiate addiction. This would equally apply to buprenorphine. And I'll let Dr. Kaltenbach refer to her recent study with her associates, which compares methadone to buprenorphine in the neonates and the differences in withdrawal symptoms or length of stay in hospital. That's more appropriate, I would suggest, for Dr. Kaltenbach. I'm just planting the seed for those of you who plan to participate in that webinar as well. And the next of the closing points is that effective medical maintenance treatment with methadone has the same benefits for pregnant patients as for patients in general. In addition, methadone substantially reduces fluctuation in maternal serum opioid levels, so it protects a fetus from repeated withdrawal episodes. And that's a significant issue about an opiate-addicted mom who's not in treatment. Whether it's heroin or prescription opioids, this is the mom taking these medications when she can get access to them. As a result, the mom is not stable. There are lots of spikes instability and neurological activity, and it affects the mom and the baby. Finally, this issue about breastfeeding being safe. Breastfeeding is safe for the methadone-maintained mom and her baby. It is not something that should be discouraged, and this is also referenced in Chapter 13 of the tip that's been referenced. Now, the problem here is if the mother has an infectious disease, such as HIV infection. Hepatitis C positive women are also able to safely breastfeed, but they should check with their physicians first. And Dr. Carol Kaltenbach, I'm sure, will go over this. And finally, the recommendation, which reinforces what's been said all along, is that representatives should work with OTPs and read the publication Tip 43, and especially the chapter on treating pregnancy. And the last two slides only talk about where our next conference will be in April of 2012, and my contact information, should you have any questions and want to get to me, although you have now a fair amount of information and reference points. So I know there may be questions, so I will basically conclude my presentation really to allow for as much of an interactive portion as possible in the time remaining for the webinar.
Mark, thank you so much. We have had a series of questions around a couple of broad themes. One of them is around payment for medication-assisted treatment. Now, I recognize that Medicaid plans vary by state in terms of what their coverage is for drug treatment broadly. But what could you answer about medication-assisted treatment and particularly opiate treatment that varies by state under Medicaid?
Well, there are about 47 states and the District of Columbia, Puerto Rico, and Guam that have access to the use of methadone and buprenorphine for patients. I'd say there are about roughly 15 states that still don't provide any access to Medicaid reimbursement. Now, this is a problem that we've discussed with various states and also with SAMHSA as well. What happens in these states is that the people that are able to access care, if there is no Medicaid reimbursement, is if either the city or the county or the state provides funding to the treatment program and allows indigent patients to be treated without charge. The second, and far more prevalent, is that patients are then making out-of-pocket payments for treatment. And these out-of-pocket payments vary, but the standard weekly payment structure is somewhere between $70 and $80 per week. There are obvious variations in that, but that's generally what happens to patients who are accessing care, especially in states where there's no Medicaid reimbursement. Generally, priority is given. Certainly, at the federal level, in the Center for Substance Abuse Treatment, priority is given to women in need of access to treatment, and that's generally where you see states, cities, or counties providing access to funding, but that is not always the case. The final point I'd make on this is in advance of health care reform, which gets fully implemented in 2014, we are encouraging OTPs in states to engage in the discussion of having Medicaid reimbursement for patients who are eligible for such care.
One of the other, thanks very much for that. I know that this is sort of a evolving situation in the era of implementing the Affordable Care Act. So those of you that may be in state agencies that may be grappling with some of those issues, how this plays out in your state is certainly a priority to work through in for this particular population in child welfare specifically. There's also a few different questions that came in around dosing, and we hear about this in terms of, we mentioned previously that we've had situations come to our attention that judges may require a particular patient to reduce their dose, or they want to see a reduced dose before they will reunify of methadone. And also questions about, are there standards or is there a formal dosing guideline that child welfare should be aware of? Can you speak a little bit about how dosing is determined and how child welfare and the family court should be looking at the doses of methadone or other substances that are being used for opiate addiction?
Certainly, and again, this is embedded in the response is included in the chapters of TIP 43. That's the federal guidelines compendium of recommendations on dosing. The first response to the question is that the dosage that the patient is on is not a significant issue at all, and it should not be, as long as the patient is stabilized. You might as well ask the question, well, do you have the use of an antidepressant? What's the dosage of that antidepressant? Or what's the dosage of the patient using a hypertensive medication? In such instances, the dosages are not relevant. The principal question is what's happening with the patient. Is the patient doing well? Will the patient do better on 60 milligrams versus 80 milligrams of methadone? And the answer is not necessarily. If the patient is stable on 80 milligrams or 120 milligrams, that's what the patient needs. This is treating. And remember, we go back to what Dr. Alan Leshner said in his article, that addiction is a brain disease, and it's on top of other obvious social issues, which is where the counseling comes in. However, if you accept the premise that we are treating a disease and we have a medication or series of medications which are effective in treating that disease, what you don't do is play doctor. Judges, child protection workers should not be engaged in saying to the individual, by the way, we think you should be on a lower dosage. Based on what? Does that necessarily make the patient more stable? The answer is you have the patient in front of you. We frankly don't understand the court interventions when the majority of the individuals in a court don't have a medical background. They don't have the understanding of the pharmacology of the medication. And while it's safe to conclude that the average therapeutic daily dose of methadone, let's say, is somewhere in the range of 80 to 120 milligrams per patient per day, there are lots of variations on that. The issue of dosage is the patient stabilized? Is the patient using other drugs? If a patient is in a program and is using heroin, almost always the dosage is simply not adequate. It's not at the therapeutic dosage range. And that's between the patient and the program. That's why the program is supposed to be collecting toxicology reports on the patients, and then the clinicians are supposed to be using those toxicology report results as a way to guide therapeutic dosing and decision-making. But the bottom line here is that it is unwise to tinker with the dosage unless you have access to all of the information, which either the programs do or the physician prescribing buprenorphine or Vivitrol would do. But this issue of if you're on a lesser dose of medication, you are improved is not based on evidence. That is mostly based on an opinion. Does that help clarify?
I think so. Thank you. There's also a couple questions or statements from practitioners in a couple different places that say that, frankly, the department, meaning child welfare department, will not support returning a child when the parent is on methadone. Obviously some of this is basic education that needs to happen, but what advice would you give to perhaps treatment providers that are providing medication-assisted treatment, and they have this sort of either local or state policy in child welfare how would you advise them to proceed?
Well, this is an important policy question. This goes beyond the individual treatment of the pharmacology. This is more where you have two parts of this. One are the treatment providers providing access to good information to the child healthcare workers, to the child protective services, but also this is a function of the state governments too. In each and every state where opioid treatment exists, you have a single state alcohol and drug abuse authority. And under their authority, you generally have what are called SOTAs. And these are the individuals that provide regulatory oversight to the OTPs. And these are the state opioid treatment authorities, SOTAs for short. In this particular case, when you have policy at the state or county level, what you are looking for is optimally an integration so that the Alcohol and Drug Abuse Authority, which has this basic information about the efficacy of treatment, the services that are provided by the OTPs in their state, that they are informing the policies of child protective societies, workers, state administrations, which basically support the points that have been discussed. And I'll step back from this for a moment. You know, the issue here is driven by practicality, that for policies to work, for parents to be unified with children, if that's the ultimate goal of all of this, that you want to be certain that your policies are working in conjunction with the goals you aspire to attain. And you don't want to come up with dysfunctional policies which basically subvert those very goals. And I think that in this particular case, what I have found in talking with states from one to another over the course of more than 25 years is that the states and their policymakers tend not to be connected to one another. And so my basic recommendation is for these states and counties to really share this information so that they're not creating policy in a vacuum.
Thank you. That's very helpful. There were a couple of things that I think I can answer sort of briefly. A question that came in about which of the states have medical marijuana laws, and refer you back to the NCSL website that maintains a registry of all of the state laws, and you can do a search on their website for things that are specific to medical marijuana. There was also a question that came in related to confidentiality, that the communication between child welfare and the OTP is limited by 42 CFR. There are a lot of materials on the National Center's website, so the website address that you see at the bottom of the screen, ncsacw.samhsa.gov, related to creating confidentiality agreements. And I think when Mark was asked what would you do if you were a child welfare worker about a particular case, and his first statement was, I would seek a confidentiality provision so that you could discuss the particular family with that particular provider. And if that isn't available in your jurisdiction, again, I would ask you to get in touch with us so we might be able to help with that. And that if there is a reason that that individual patient is not willing to sign that confidentiality agreement, sort of delving into more of what are those clinical issues that are going on, that communication is not being provided, needs to be addressed in work that the worker could do with that individual parent. But there are certainly ways to make that communication happen, and we would invite you to contact us if there are specific questions about that. Then, Mark, there's a question about why those three particular states. The question came in is why the three states don't have regulatory oversight of OTPs. And I think that might be somewhat misunderstood in the state having the oversight versus the availability of OTPs in those particular states. Could you address that, please?
Yes. I mean, the state authorities exist. There is no access to treatment in those states, which means there's simply no opioid treatment programs operating in those states at the present time. Why is that? As I understand it, the states have claimed that there is no need for treatment in those states. I've not spoken with those state directors recently. We do know from the studies we've done and from communication with the OTPs that there are a number of patients who cross state boundaries to access care. As an example, in the study I referenced earlier, there were 46,000 patients that completed that opioid prescription study. We know that 15% of those 46,000 patients cross state lines based on the zip code data that we've analyzed from the patients completing the survey instruments. We assume that a number of people in those states of North and South Dakota and Wyoming probably are crossing the borders to access care in the adjacent states. We don't have a lot of information on it. We know there's some of it.
Okay, thanks. There's also a couple questions about different medications and are they addictive. It seems to me that we need to sort of do an explanation of the difference between dependence and addiction. In particular, the question came in, is Suboxone addictive? I think that explanation needs to still perhaps be addressed.
Well, all medications that have either agonist properties or partial agonist properties, methadone or buprenorphine, are dependency producing. That's true. Now, the reason you want to separate this from the term addiction is addictive behaviors are either drug-seeking behaviors, they are self-destructive behaviors. As an example, if you have a person who's using heroin or prescription opioids and they've crossed the line, they are addicted to them, they're engaged in behaviors, doctor shopping, or the classic issue of someone, let's say, as an example, a realtor showing a house, going into the medicine cabinet and taking drugs from the medicine cabinet, or people who are out on the street using heroin or other drugs, cocaine. Addiction is also a matter of behavior. It's a matter of the drugs they're using. It's as Dr. Leshner talked about it, and NIDA publication talked about it, this issue of uncontrollable craving. Dependence. You are dependent, and this is a simple way to know about dependence. You take a certain medication or a drug or alcohol or coffee or nicotine. You stop using it, you're going to have physical symptoms of withdrawal. You're going to be in discomfort. And depending on the length of time you've used the drug or the amount of drug you've used, the discontinuance of that use of drug creates physical withdrawal symptoms. That defines dependence. Without any question, the use of methadone, the use of buprenorphine are dependency-causing drugs. When you are in a treatment program or you're under the physician's care in a Data 2000 practice, it is not proper to reference that patient as being addicted to that drug. They are dependent on that medication. That is the more accurate scientific nomenclature that's used.
Okay, thanks. Are there medications that are available for other kinds of addictions, for other substances? Would you address what's being done with cocaine, marijuana, methamphetamine in terms of medications?
I mean, those medications are still in trial. I know that NIDA has funded a number of studies that have had mixed results. We do not have a comparable medication, as an example, to treat cocaine addiction. We just don't have that. We haven't been able to track that yet. And the focus of using medications, whether it's naltrexone or Vivitrol for alcohol and chronic opioid addiction, are medications. I know that in the future so-called generation of medications, you're dealing with delivery systems. such as implants, like a 6-month buprenorphine implant. These are in early trials of research. The question always comes in, as I repeat from earlier in the discussion, is what is provided in addition to these medications. But these are primarily the medications that are used either for treating addiction or alcohol, which is approved by the federal government. The point is there are not many of them, and there is nothing that has been demonstrated to be effective in treating cocaine addiction at the present time.
All right, thank you, Mark. Two questions that are somewhat related, and I am mindful of the time, so we'll do these sort of, I think, quickly. But one is, frankly, a statement that says, are you suggesting that a person would never withdraw from methadone? And parallel to that is, so when would a person be stable for a child to return home if they are on methadone?
Well, the answer to the first question is that no, I am not suggesting that all people will need to be using such medications for the rest of their lives. But some will be using their medications for the rest of their lives, and we should not treat that any differently than the use of medication to treat any chronic relapsing disorder. However, I can tell you that, and by inference, if 75% of the patients will relapse, that means 25% or so will not relapse as a corollary. So there are a number of patients who will successfully withdraw from the use of medications, whether it's methadone or buprenorphine. Again, it's an issue related to brain chemistry. It's a matter of genetic makeup. It's also a matter to duration of pre-treatment opioid addiction. It's related to stability, working, family life, connection to the community, general health. So those are general issues related to, will a person be able to discontinue their use of treatment? Some will. The majority will not. And the rule of thumb, basically, which most treatment practitioners know, is withdrawing from the use of a medication is not the critical issue. It's sustaining the withdrawal. In other words, it's sustaining being in a so-called completely drug-free state. The issue of stability of when a family is reunited, when the mom can, recover custody of the child or reunify, it's not going to be related to the issue of, is the person in medication-assisted treatment or the dosage that they happen to be on. It's a matter of their general stability. And you arrive at that by obviously meeting with the patient and discussing the case with the treatment program once the release of information has been obtained. So, if the mom is actively using other drugs and is enrolled in a methadone program, obviously that is not a person who should be reunited with their children. And that's a fairly straightforward approach. If the mom is clearly involved with criminal action, or there are behaviors that clearly indicate that this is not going to be a stable parent, these are different issues. So it is not related to when is the mom stable. Now, the question becomes, if a mom enters treatment and is in treatment for 1 week, does that mean the mom is stable? Almost always the answer is no. It generally takes several months for stability to be achieved, but this is also directly related to the individual. Generally, from a pharmacologic perspective, it's generally going to take at least 1 month of continuous treatment for an individual to become stable from a purely pharmacologic standpoint. It may take longer in certain patients' cases. And in some cases, they may never achieve that sort of stability. There may be difficulties that the patient encounters continually.
Thanks, Mark, very much. There was a final question that I'll address related to providing education to judges. And at the National Center, we are very involved with that effort, both through the National Council of Juvenile and Family Court Judges. If you're not familiar with them, they're a national organization based in Nevada that provides training to judges. In addition to that, the Children's Bureau funds in all of the states a court improvement project that is funded out of the Child Abuse Prevention and Treatment Act. And the Court Improvement Project, or CIP, provides education to judges in all of the states. If you are not familiar with who runs the Court Improvement Project in your state, please be in touch with us and we can refer you to that state director of the CIP, because generally, particularly all of the large states, hold training conferences for judges at least annually. And we would encourage you, if you are a treatment provider that believes that your particular state, that the judges need education about this, that this is something that would be, we'd ask you to reach out to that Court Improvement Project state director and get on their agenda and be able to provide the education in your own state about the programs that you deliver and about medication-assisted treatment in the context of child protection and child welfare services. And if we can be helpful to you in that regard, we would again invite you to be in touch with us about that. Let me just thank Mark one more time for being with us today. I would invite you to visit his website and also to take a moment to complete the evaluation. When you close out of the webinar, you'll be directed to an evaluation. We would appreciate your feedback. If there are questions that we did not answer today, please be in touch with us so that we can make sure that we can address those in the webinar that will be held on August 4th. And you've heard a bit about that already, but we would encourage you to register for that with Dr. Carol Kaltenbach. With that, let me ask Han and Kathleen, any further details we need to cover? No? All right. Thank you so much, all of you, for your participation today. We look forward to hearing from you in the future. And again, Mark and your organization, thank you for the work that you're doing on behalf of families across the country.
You're welcome. Thanks for the opportunity to participate.
All right. Bye.